This is Regan Thomas, who's one of our own, an MD, 72 here at Mizzou. Did a surgical internship at Yale, and then came back to Mizzou for his ENT residency program. Spent some time in private practice, and then did a fellowship in facial plastics in reconstructive surgery at Northwestern University. Came to Washington University on staff there. We developed the division of facial plastic and reconstructive surgery, and then became chair of otolaryngology at St. Louis University. And then from there I moved to University of Illinois in Chicago, where he's currently the chair of the Department of Otolaryngology. He has authored over 200 scientific papers and publications, including 5 textbooks, and more recently edited the Advanced Therapy in Facial Plastic and Reconstructive Surgery. Past president of the American Academy of Facial Plastic and Reconstructive Surgery and the American Academy of Otolaryngology, Head and Neck Surgery. Probably more importantly, he is this past recipient of University Medical School's Citation of Merit Award. It's the highest award awarded by the School of Medicine. And as you can see, he is my sartorial antithesis, a damn snappy dresser. And he is one of the few people I know who can truly rock a pocket square. Dr. Thomas, thank you so much for addressing.
Thank you, sir. Well, and I just want to say that Citation of Merit thing, I was truly honored and surprised. And I've been saying probably no one was more surprised than me to have that wonderful honor than perhaps my classmates who were here. I'm sure people are going, Regan Thomas, that's the one? So. Well, I'd like to share with you one of my passions here, and that's facial scar revision and camouflage and the work that we do with that. I'm a guy who's had a nice life based on most of the time doing facelifts and nose jobs, but one of my passions along with that practice through the years is dealing with facial scars and all the implications of that. I have nothing to disclose, sadly, and so if you know any corporate types who'd like to give us some money, I will change this slide as necessary. Well, I'm also going to interact with, I have a lot of classmates here and getting ready for the reunion, and want to thank them for coming back, and I'm really looking forward to getting together with all of you, and I thought I might share a couple things and take advantage of this. In the days when we were here, you could shift your clinical rotations around, and so I took senior rotation, senior surgery in London at St. Mary's, and then had shifted my free blocks, as we called them at that time, kind of vacation time to the end. And so I spent the last 5.5 months or so of medical school in London and ended up looking like this. This is sort of, do not let this person get close to your daughter. And so we were there. We, again, had a great experience at St. Mary's, and but in my John Lennon phase, as you could tell. Cleaned up a little bit and came back for graduation. Got rid of the beard, but sadly did not get rid of the hair. But in my defense, I was not the only one. And you remember, see if I can go back one there. Let's see here. Yeah, Bob Warren here, and Joe Wackerly, who was an ER person in Kansas City, I think. Steve Grace, who's retired, who's OBGYN person in Springfield. And so same haircuts, and so I wasn't the only one guilty. Went to Yale for a while, as you heard, and see if I can make that work. So guys, help me out here, because it's not advancing here. Maybe I can do it that way. So went to Yale, and got a little bit of a haircut, but I noticed all the cool guys were growing these mustaches here, so I came back this way. I am so sorry to my classmates here. This is my homage to, and so this is changing on its own now. So again, if I have yeah, so can you make that stop? Because I mean, I'm not doing anything, it's just changing. Can you hear me up there? So with that, maybe we'll try that. Okay, so Frankenstein here, I guess the point with this is that nobody wants a scar, and it's not a positive accolade except maybe to Frankenstein here. But for most of us, having a scar, particularly on our face, is a real issue. No one wants a scar any place. Yeah, thanks. It was just jumping along for some reason, so I think it's under control now. But if you have a scar on your arm or your back, you don't want to have that, but you can tolerate that. On the other hand, when it's on your face, it has very definite implications that are different in terms of your self-confidence, your self-image, in real life sorts of things, your ability to interact socially. Think about a young woman like this in terms of dating issues and social activities, job interviews. In fact, just this year, an interesting study came out of looking at people with facial scars and some other facial deformities at an interview session, and it turned out, not surprisingly, that people remembered more about their scar than they did about the conversation, the interaction with those individuals. So it has real implications. These are not life-threatening. On the other hand, they really impact your life. And so being able to interact with these people. A lot of this stuff here, it's got some ENT pals here, so all of this we've got published here in various interesting books and that kind of stuff are hopefully interesting. Well, one of the things we do when we interact with scars, and those of us who do this kind of work, is some of the scars we can impact initially. And so what we do at primary repair and the things that you do when you see someone in the ER makes a big difference in what kind of scar. Maybe you can make them avoid having to have scar revision later on. One of the key factors is remembering to preserve the natural landmarks and boundaries. So like this fellow, chainsaw injury, we're going to sew that up in multiple layers and appropriate suture material and all the things we can do to get the best healing. But we're also going to be very careful to realign the mental crease and the vermilion border and the nasolabial crease and so on, and maybe make that scar revision easier. The other concept in this self-inflicted gunshot wound is, remember, for those of us at least who work in the head and neck, we have that enhanced blood supply there, so we can get by with things. So remember early on in med school, and you go through surgery training, you learn to debride that area and get nice straight edges. And what I'm going to show you in a moment is doing this sort of jigsaw puzzle area, and we can get these little pieces to heal in the face. And this irregular, unpredictable scar is ultimately going to give us a less noticeable scar than a big saber-like straight hash mark there here. And here's an example where someone didn't do that. Little boy through and through lip laceration. The ER folks sutured him up, and I think did a great job in a tough situation. You know, a child, very smooth skin, you can't hide that. But what they forgot to do is realign the vermilion border, that anatomic landmark. And now he's going to need to come back and get that fixed, even though the scar itself really looks pretty good. So given we have a scar, and we spend a lot of time talking to our patients about once you have a scar, it's permanent. You can't make it go away. And people come in with, you know, Googled things they've done, said, well, with a laser you can erase this, and you can't. Once you have a scar, it's permanent. So our goal is to try to get the best scar that we can. And so these are the sorts of things, and particularly when we are creating the scars, and I often tell my residents and fellows that doing scar revision work has made me a better surgeon, in that I begin to think of these sorts of things. And so we'd like to ideally have scars that, and look particularly incisions, the scars we're creating that fall into the junction of facial landmarks, so the junction of the cheek to the ear or nasolabial lines and so on, using the so-called relaxed skin tension lines, or some people call these resting skin tension lines, those normal lines and areas of tension that we have to hide them. And so doing that helps us. Relaxed skin tension lines, you'll hear me mention this several times, but basically those lines that most of us are beginning to see in the mirror every morning that follow along the wrinkle lines and so on. If you have an incision or ultimately a scar that's perpendicular to that, it shows up. Your eye catches it. If you have one that goes into that, it's less noticeable, as well as has less tension on it, so it's less likely to be a widened scar or a less appropriate scar. And so little things of maybe being a better surgeon, thinking about those kinds of areas. We have this sort of thing, and we could excise that and repair that in a lot of ways, but we know that we can hide that in the nasolabial crease and go from this to this with really something that doesn't show. Or here, you know, benign sebaceous cyst in the person, but we're going to excise that and bring that out and dissect that out in an incision that I'm putting within the hairline. So when we close that up, it's hidden in the hairline and be less noticeable. Or this we deal with a lot of times, and Larry Milliken was here. Oh, he's still up here, taught me how to take care of these things a lot through the years. Pretty young woman who, too much sunshine, basal cell here on her lip. I work closely together with my Mohs dermatologic surgeons, and they get all the skin cancer out, pretty big hole in that person's lip. Number of things you can do. You can put a skin graft on there, it'd heal great, but look kind of funny, look like a patch on the lip, other things. And so we're going to use our knowledge of reapproximating, you know, skin edges so that they go on the resting skin tension lines. We bring that lip line back up to the normal area, and here she is postoperatively. And we've gone from lesion to a big hole to something that's less noticeable. similar thing, smaller hole, but same idea here, is trying to get those scars so that they're not noticeable. There's a scar there for sure. There's a defect in the lip, but we repair that. And so that's the idea. So that's the sort of thing that doing the things I'm going to tell you about actually makes me a better surgeon in terms of where I make and how I make scars that I iatrogenically am creating here. Well, if given we're going to have a permanent scar, can't make it go away, can't erase it. And by the way, again, I spend a lot of time talking to the patients and the patients' families that we're going to try to make this scar better, but I can't erase it. You're going to have that scar forever. But a scar that's flat and level with the surrounding skin, meaning we don't have a depressed scar, we don't have a hypertrophic or elevated scar. It's one that's flat, it's less noticeable. Ideally, if we can get it to be the same color. I think the patients understand that by and large a narrow scar is better than a wide scar. And we talked about trying to have those incisions and scars within the favorable skin lines. And the thing that's most useful to us, and on the other hand is hardest to get patients and their families to understand, is that irregular sort of sinuous scars, an optical illusion of scar revision, makes these often less noticeable than a straight harsh scar. It just sort of intuitively makes sense. A nice straight scar would be better than one that's sort of zigzaggy. Turns out if done properly, that's not the case, and so we do that. This is an algorithm that Rich Holt, another University of Missouri grad, and I put together a number of years ago. There's some other modalities that we would add to this now, but it still holds up. But the purpose of the algorithm is just to say we analyze scars just like you analyze any other clinical challenge, and there are a number of ways we deal with that. And then finally, I don't have time to talk about dermabrasion, but nearly all the scar revision techniques that I'm going to show you here quickly combine with them a second stage dermabrasion to further smooth and blend that. And so that's helpful as well here. Well, sometimes the simplest thing is the best. If we have a scar that's kind of going the right direction, it's maybe parallel to the resting skin tension lines, but it's depressed, we can simply excise that and repair it properly. And just a fusiform, a single excision is all we need. Again, we want those fusiform excisions to be in the resting skin tension lines. And in the face, by the way, if you make a football shape, a fusiform, what we want to do is by and large bring it out to about a 30-degree angle. If that angle is more obtuse, you tend to get a dog ear or lumpiness there. So we try to do that as well. And so again, here's a great example of something that doesn't seem like that big a deal. She has a chicken pox or sort of thing on the end of her nose, but a huge thing for this young woman here at school. People make fun of her, tease her about her nose. She's very self-conscious about that. I suppose a number of things you could do that, but by simply excising that in a fusiform fashion, coming back to a little dermabrasion, we almost make that disappear. And a really rewarding sort of thing to get this young person, next time I saw her, her hair is fixed, she's wearing makeup, she's feeling confident of herself back in high school, with that. Here she is, going from this to this. So what seems like a simple thing. A psychiatrist friend, bicyclist, kind of a big-time triathlon guy, fell off, ran into a car and fell off his bicycle. But you don't need to do those other, we simply re-excise this to get him back to a better lip impression. Now, remember we talked about we want a scar that's flat and level with surrounding skin. So here, this initial surgeon probably did a pretty good job of closing that, but forgot when they excised some sort of cyst here that we need bulk and contour. So there are scars that, in addition to making the surface better and the scar better, basically utilizing these principles we're talking about, we also add some volume. And for me, that's often a dermis fat graft. So I steal some dermis from down below the bikini line, or maybe from an appendectomy incision, that sort of thing, and bring that up and fill that up. Still a scar there. We try to make the best scar that we can, and here she is about 6 or 8 months later. But we've gone from this sort of look to this, still a scar, but one that's less noticeable here on that sort of permanent scar. Sometimes we can just shift the scar around, what I'm calling scar repositioning. And so we can't get rid of the scar, but maybe we can slide it around or bring the edges together in a different way. So this young woman, someone had excised something here and left this. It looks like, she said, this looks like the emblem for I always get Star Trek and Star Wars mixed up. Star Trek, but it looks like the emblem that they wear. So this triangular kind of funny thing. Well, there's no reason on this young woman to leave this wide, depressed scar area here. And so we're going to shift that scar. I'm going to use this normal skin here to push that up, bring these edges together. Here's our operative plan. I'm going to excise all that funny looking Star Trek scar, close it, still a scar there. I'm trying to get it to fall within those resting skin tension lines as much as I can. We come back, it looks worse before it gets better. Here at about 6 weeks, we come back, we're going to dermabrade or sand that scar and get her back. That scar's still there, but it's less noticeable than before. This fellow I'll come back to in a minute, burn patient, but one of the things, and again, you need to be cognizant of how important these things are on the face to patients. And so this really bugs him. Here's a guy with scars all over his face and neck, and one of the key things is it's pulled his lip down. And so by excising that, advancing it back up, shifting the scar repositioning, and recreating a normal landmark gets him back where you don't pay attention to his funny looking thing on his lip. And people were always pointing at that to him. I'm just going to digress for a moment here, and I got a couple of my buddies here in the Otolaryngology department who do a lot of this kind of work here with us, and see these as well, are keloid scars. These are scars that don't fulfill that ideal scar. They keep on growing, almost neoplasm-like here. And keloids are a real problem, very interesting area. Most of the ones we see in the head and neck, although you can get them in other places, of course. In the head and neck, the most common thing is people who are keloid formers pierce their ear, a little tiny hole in the ear, and it ends up looking something like that and keeps getting bigger and bigger in some people. Guys with shaving, will get little cuts and ingrown hairs. They heal by a keloid and some terrible sorts of things. So dealing with these, and I point this out in that saying that the stuff I'm going to show you here in a moment in terms of irregularizing and so on scars are not for keloids. Because if you did this zigzag sort of thing I'm going to show you in a moment, you would get a zigzag keloid. You don't want to do that. Just in passing, we take care of these. That's different than a hypertrophic scar that was our first example. So we can do that to these. But the true keloids, that, this sort of thing from piercing your ear, grows like that. In the United States, we tend to think of this as an African-American issue. It's in all races. In Chicago, where I have a wide spectrum of ethnic backgrounds, see it fairly often in the Latino population as well. Most of my patients are African-American. You see it in fair-skinned Caucasian people as well. It's a familial trait. Just so happens in the gene pool in the United States, we see it in African-Americans more often. But, pretty deforming thing. Think about going to high school with that. That's going to be tough. So the stuff we're talking about here, don't do these other things in keloids. Keloids, how we treat them are excising it and resculpting this back to normal look. Serial steroid injection, triamcinolone. We do that at about 2 or 3 week intervals for a while. Follow that up with stretching out to maybe monthly or 2 monthly intervals. And finally, it quiets down and stops. And we have good luck with that. We try to use local pressure, which seems to help with these. Sometimes in resistant areas, we'll use low dose irradiation. That's a first-line therapy for some individuals, and other concepts that people are trying of maybe injectable 5FU with that. So these are the kinds of things that we're doing, Keloid, steroids kind of stuff. And I tend to, because a lot of these people I'm seeing are in younger age groups, try to avoid that RT in those patients, particularly in the head and neck. But here's what we're able to do. Go from this look to this look. A lot of the times, again, in our African-American patients, we get a little hyperpigmentation, but a good trade-off. There's that big one we were showing you. I can get her back to that. Serial injection. Finally, she doesn't have to wear it, worry about it, can wear earrings and that sort of thing, go from this deformity. So it's a real scar, going from this bizarre-looking sort of thing to something that kind of looks like an earlobe. But we get her from these big wads of scar out here on her cheek and ear to something that you don't notice and don't pay attention to. So, and just another interesting one in this gentleman here to get him back from this funny, bizarre stuff to this. And we do that with excision, sculpting of the scar, and then serial Keloid. So point being, don't do these things that I'm going to finish up to talk about. Well, a basic principle of plastic surgery and scar revision surgery in the facial area is the concept of Zplasty. And so there are scars that contract, and indeed all scars contract, but some of them contract enough that it becomes clinically a problem. And so Zplasty allows us these transposed flip-flop flaps that I'm going to show you that we do. So typically the Z is the center component. We excise that and flip-flop these Z-like flaps. And what that does is the Z components come in and they push sort of point A to point B, push it away because we're bringing in more tissue. We can change the direction of the scar and try to get it so it follows more closely those resting skin tension lines. And then, as I hope I'm going to convince you by the end of this lecture, it also helps irregularize the scar. Your eye doesn't follow it as well as a straight line. So that's called Zplasty. And again, it's sort of flip-flopping, transposing these triangular flaps with the center component of the Z as the scar. So if B to C is contracted, going the wrong way, we can do a Zplasty, excise that scar, transpose or flip-flop those areas, and that stretches the distance, pushes the distance away really, so it's not contracted, and in fact we change the direction of the scar here. We usually do these, make these angles at about 30 to 45 degrees. More obtuse angles tend to kind of bunch the skin in other ways. So I'm going to see if I can make this work here. So this is a fresh cadaver. This is not a real patient. And if, there we go. And if this red line here, A to B, represents a scar, if that scar was contracted, I would like the distance of A to B to be pushed away so it's not contracting, particularly if it's close to a free margin. Scar contracts by an eyelid, it pulls your eyelid down. If it's by your lip, it'll pull your lip up. And, you know, we see out there, you can see the ear, this area here. The resting skin tension lines are going this direction that I've put the dotted line, not this direction perpendicular, so it's going to show up more. And so again, if we measure this, and I won't make you watch the whole thing, but when we measure it afterwards, point A from point B is further away. So the scar is the center component of the Z. In real life, we would excise that scar and then incise the Z components. And as you see here, I'm doing it at about 30 to 45 degrees. We're going to undermine, and it's in the subcutaneous plane here, undermine our flaps. But as you'll see in a moment, I'm also undermining the surrounding skin. And so this is a fresh cadaver, so we don't have bleeding, but I would be using my microcautery to get rid of the bleeding at that time too. Excuse me. So then we undermine, so I can slide that around. And then we're going to transpose or flip-flop these flaps here after we've done that. And this is the basic concept of a Zplasty. And then suddenly, right on the table, it's really kind of neat having young residents and so on with this, is remember we used to have a scar from A to B. There's not a scar there anymore. It's gone. And our central component now is going parallel to our resting skin tension lines here, as well as breaking this up. So that's the concept of Zplasty, and very useful to us. Now, it turns out that a lot of areas on the face, you use that Zplasty concept here, make this in a big Z, and that works doing the things we just said, but the components of the Z may show. So what we do more often than not is break that up into what's called multiple Zplasty. So instead of one big Z here, I'm going one Z and a second one and three Zs and so on. Transpose all of those. I get the same effect, but the components of it are smaller here, and so it doesn't show up so much. So that's the idea of that. So here's a person here with a contracted neck scar, an old patient here, but contracted to the point it's almost tight for her to turn her head as well as elevated. And so we could do a big Zplasty and take care of that. I'm going to break it up into these components here like this. Here it is with sutures in. Here she is a week later. And we've gone then several months later from this tight contracted scar to one that's lengthened, flattened in the face. And as her hyperpigmentation fades out, you probably won't even see that scar in there. So that's particularly useful. Here's the guy that had the lip, burn patient. And often these folks get these so-called bridal scars. This is when you go over a concavity. The skin or the scar is so tight it tenses up like a bridal rein with that. So very unsightly, sometimes limiting in motion. I can stretch this point and relax this with one big Z, but it looks better if I break it up into multiple here. I think we have about 10 of these little Zplasties, transposing those. And here he is postoperatively. Now you know where to look for his, there's still a scar there, but it's much less noticeable than this, and we've done that by lengthening point A to point B. By scar as well, it makes it harder for you to see because it's irregular here, hard there. Another area where we use this are so-called trapdoor scars. Some people, older literature, call these pincushion scars. This can come from trauma, or more often sometimes come from perhaps poorly planned local flaps after skin cancer. But what happens, again, all scars contract. And so if you have a circular or semicircular scar, it contracts. And what tends to happen is it bunches that tissue in the middle. So you have this wad of stuff sticking up there. Well, what we can do is elongate that scar and have the tension going in different directions through these multiple Zplasties. So like in the diagram, I can put multiple little Zs, or this patient here. I'm going to excise the scar, undermine in these areas, break it up into multiple little Zs. I think I sneaked an extra one in here. Here she is. And now, still a scar there, but we have a scar that you don't see as well. It's not bunched, it's flattened in the face. And in spite of my best efforts, she still has a Hannibal hairdo. She's from Hannibal, Missouri, came up to see me here. I guess Mark Twain had like those in the back of the day. So that concept, here's an attorney, actually a plaintiff malpractice attorney. My wife is smiling back there, she probably knows this guy. Excision, you know, nice closure, but he has this wad here. He's self-conscious about that. Doing those multiple Z-plasties around, we can get him from this to this. Still has a scar there, but one that you don't notice and it's flat in the face. So that's Z-plasty. Well, sometimes here we have a scar that's not contracted. We don't need to shift around. We just need to make it look less noticeable. And so the last two things I'm going to finish up with are called W-plasty and one called geometric broken line closure. And W-plasty basically is a zigzag sort of area here. So these are interposed flaps from one side of the skin. We're not transposing, not flip-flopping. We just make this zigzag W-like configuration, making those components in the resting skin tension lines again. And then we make the mirror image, and then we excise the scar, and we bring this together. And the hard thing to get folks to understand with this is that it's an optical illusion. Your eye does not follow that zigzag in the same way it will follow a straight scar, especially if the zigzags are within those resting skin tension lines. I use as an example the patient's military camouflage. So if you have a big truck or a tank and you do that camouflage painting where you're putting big splotches of green and brown and stuff on it, you'd think those big spots would show up more, but what happens, your eye doesn't follow it, and so camouflage stuff blends back into the background again. So we're kind of doing that as well here. So this is the most common scar procedure I do on that. And again, in terms of planning, and Dr. Renner, who's back here, who's a real expert at this as well, you know, where you try to plan these so that these are, the components are in the resting skin tension lines as well with our planning. So here's a patient, excision by our dermatologist here. They worked hard, but just not a good scar. And so here she is after W-plasty. So how did I get her from this appearance to this appearance? And we did this with this zigzag thing, the so-called running W-plasty. If you read the British literature, it's running M-plasty there. So here's our plan. We're going to excise that scar, but rather than just close it up where it may contract and become depressed or be a line that you can see, I'm going to break it up into these W's, these zigzag area. Now notice technically I'm leaving the scar underneath in place. It's just the surface area here that helps support the base of the scar here. It's not a neoplasm. You don't have to remove it. Close it together. I'm doing this suture. Here she is a week later, taking off her stitches and steri strips, and we go, as you saw, from this to this. Now in close-up, you can see she still has a scar there. You know where that is. You can find that scar. But I would argue the scar is less noticeable to your eye than her normal facial rhytids and wrinkles here. So that's W-plasty, very useful. I'm going to run short on time. I'm not going to take up time doing on that, but basically we do about 5 to 7 millimeter zigzags like we showed in the diagram and enhance the scar. So here's a young woman, car accident, happens to be the daughter of the president of the AMA at the time, and interesting young college co-ed here. So look at her scar. Does it fulfill any of the characteristics of an ideal scar? Well, first of all, it's not running within the resting skin tension lines. They would be going this direction. It's not a narrow scar. It's a wide scar, particularly out here. It's not a flat scar that's flat with the surrounding surface. It's elevated a bit and so on here. And so I can't make the scar go away, but hopefully I can get it so it's less noticeable and in a practical way, particularly for young women where she can more readily cover with makeup. So here's my operative plan. I'm going to excise it, but I'm going to do it in these zigzag W-plasty, if you will, directions. These are planned to go in her smile lines. I'm going to excise that. Here she is with closure then and stitches, and those are there. Here she is after dermabrasion, and I do that about 6 or 8 weeks afterwards. And then here she is. So still the scar there, but I would argue a lot less noticeable than she had before. And again, as a young woman who is probably using makeup and so on, a scar she can cover with makeup, which she couldn't cover with that. So here she is without makeup and so on. Recent one here, chin scar. Not the worst thing in the world, really bugged her. She's a salesperson for a big time computer situation here and seeing clients. This bugged her all the time. So W-plasty, coming back, dermabrating, and we've gone from that former thing. So here's her old scar, and now we get her where you don't notice it as much. And go from this look to this look. Just some other quick examples here. She's got a lot of makeup on, but again, that's part of what we're trying to do is get this so she can hide that better. And again, I would argue if I put her up and said, do you think she needs her nose fixed, you might not even notice that scar. That's where we're going here. So, and another gentleman, and just before dermabrasion, and then after. And just the last young man I just did, college student there, car wreck, as often these are, ZPplasty, and still a scar there, but we've gone from that to that for him. So makes him happier about it. And lastly here, there's something called a geometric broken line closure. So if those W's, if that running zigzag fools your eye, what if we went the next step and made it even less predictable? Made little squares and rectangles and so on. It makes it even more of an optical illusion for you. It makes more of a camouflage. The reason we don't do this all the time is twofold. One is that it takes a lot more time to do this. And secondly, that some of the little rectangular and square shapes automatically mean I'm going, rather than parallel or within my resting skin tension lines, that this little 4 or 5 millimeters, I'm crossing them. So that's the negative part, although it is more irregular and harder to predict. So I use these in areas that are very long, where that ZPplasty might become predictable to your subconscious eye, or in areas around the chin and places where it's hard for me to figure out where to put them here. So little squares and rectangles and so on in addition to that. Here's an example where we're going to use that. Really neat lady, awful thing. She was captive of this weird torture thing, and they made these big X's in her face and did a bunch of other awful things to her. But working together with her and her psychiatrist, back to ready to be out there in the world, but these big X's carved in her face. So on her, I'm doing little squares and rectangles, and the geometric thing I was telling you about closed the same way. And she's doing a good job, as you can see here. I tell all these folks, keep sunscreen on. I meant the whole face, not just where your surgery was. But if you look at the scars now after that, they're flat and level with surrounding skin. I don't think you're actually even seeing the scar there. It's there, obviously, but your eye is just not picking up on it here with that. St. Louis girl, motorcycle person, wear your helmet. And so same sort of thing. And the reason I'm showing her here as we finish up is that I have a control on her. So as you will see with her eye open, that let's see if I can back that up one. Yeah. Anyway, if you can see if her eye looks a little edematous there, they thought there might be some ptosis. And so the ophthalmologist, oculoplastic surgeon asked me not to do that. They were going to work with that later. So we've gone from this to this, except we didn't do anything to this. And it's letting you know that we can improve the scar with these techniques. And on her, it's that geometric broken line closure. It's not just time going by, although scars do better with time. But that one still looks pretty much the same. And the other areas that we treated are enhanced and better. So again, won't do that. So finishing up, just saying that the broken line geometric closure is that next step in camouflaging. And going back to that very first patient that we had, remember her, young woman, car accident, caught her cheek. I don't know how it was repaired initially, but we had that hypertrophic scar. So we're going to do geometric, broken little squares and rectangles and triangles, sewing it up. Gets worse before it gets better. Here she is a month or so later getting ready for dermabrasion, and then after dermabrasion. And we go from this to this when she's meeting somebody new, when she's on a job interview or school interview. Hopefully people are looking at her and not that scar. Hopefully she feels more comfortable that people aren't peering at that. Still a scar there. We go from this to this utilizing that technique. So again, I'm a guy who probably 75% of what I do is aesthetic, cosmetic stuff. In addition to being German, and in terms of my patient group. But this is genuinely rewarding. These patients, when things go well, it's such great feedback, and you see the changes in them in terms of what awful psychological trauma facial scars do. And I'm obviously showing you good results here, but most of the time we can make those better, and that's really, really great for that. So why I think scar camouflage is an important part of what we do in our specialty, but an important thing for you to be able to tell your patients about and let them know. And I'm quick finishing up, just my best accomplishments, again, for my classmates here. Those are my 3 kids, and you remember Rhonda here. 3 kids are all great athletes, super skiers. Rhonda points out that they obviously got that from her. This is our place in Taos here, so we're all skiers, and the kids are great. And my 3 best accomplishments in life here are probably these 3. This is my son Aaron, who is a artist, a musician, undergraduate degree at the University of Montana and grad school at the Chicago Art Institute. My daughter, who's a architect in Manhattan, undergrad at Stanford and graduate degree at UCLA. And my one Missouri guy here, UNLV hospital or hotel rather management major, and he is the assistant manager of the Kansas City Hyatt Hotel there. And so Rhonda, who's here, so excited to be back with all of you. Being here in Columbia was such a giant thing in our lives, and still impacts us and offered us sort of life here. Rhonda, by the way, during those days was city attorney for Columbia, and I think probably still was the first woman city attorney, and probably the only one at this point, and she's gone on to other stuff. But we are looking forward to spending the weekend with all of you, and appreciate the opportunity to get back together, and truly, genuinely appreciate what the University of Missouri and this medical school in particular did for us. So thank you all very much.
Thank you, Dr. Thomas. Excellent presentation. You only think of how many lives you've improved with your skill and technique. I just wonder how things might have changed much differently had you been on staff at Hogwarts, and much Harry Potter's life would have been far different. Any questions?
I just wondered what your opinion is of skin glue. A lot of times people, it comes and goes and comes and goes.
Tissue adhesive. So I don't think it's, for what we're doing here, it does not give you as good a control of edge-to-edge precision and so on. So we routinely don't do it. Where I would use tissue adhesives and so on, and by the way, those are for the surface, not the deep. You still should put typically the dermal sutures in, the real strong sutures there. And so nowadays we'll use, PDS, absorbable, that sort of thing. So it's for that surface layer. And the problem with it is it's not quite as accurate of lining things up and so on. So for me, where people are saying, we want you to do that, I usually don't do that. However, I think it's great for pediatric situation. You got a little kid in the ER and a dog bite or bicycle wreck, and you get it basically closed, and they're wanting to get out of there, and we're not giving them anesthesia because we don't want to drop their IQ. This is a joke. So I think it works really pretty well. I don't think it's as strong in terms of that initial tensile strength, and I don't think you can be quite as accurate with it. But it's good to use it, again, in tough situations where you're in a real hurry and somebody with other trauma. In the pediatric age group, I think the tissue glue type stuff does okay. Sure, not bad stuff. Not as good if you've got an hour to sit there and put all those little tiny 6 and 7/0 sutures in.
Regan, great talk. One of the things that we have at Vanderbilt.
I'm just interrupting. I think it would be appropriate if we could turn off the University of Illinois slide here. Okay. Sorry about that.
One of the things that we have at Vanderbilt that conceptually works really, really well is they have what's called a FACE team. And the FACE team is composed of the guys and gals from plastics, ENT, and oral maxillofacial. And they share call for facial issues. And so like every third night, one of those groups will be on. If they have a lot of business, they roll more in. And so they end up doing, really definitive primary repairs that obviate the need for maybe secondary or tertiary things. And it works really, really well. So that's something that people, I think, really need to think about if they're not doing it in other places.
Well, that is a great team, and I have good friends from the otolaryngology facial plastic side there. We do the same sort of thing. So we have ophthalmology, us, and oral surgery together on head and neck sorts of things. And general plastic surgery does the same sort of thing with dermatology and so on sort of body injuries and stuff too. So, but exactly right. So.